Okay, maybe we can get started, just because I'm aware that the formative is coming up soon, and I'm sure some people can join in. If they come a bit later, that's fine. Let me get all of my things. Okay, so hopefully everyone can see my slides. I should be able to get notifications from the chat. So if you have any questions, feel free to post it on there. But equally, feel free to interrupt me at any point. I really don't mind. So it's quite a number of topics that we're doing today, skin, breast, and gynae, but hopefully we're going to try and cover the key things that are much more likely to come up. And then some more comprehensive tables and things like that for you guys to have for your revision in the future as well, when it comes to the summer. So, okay, so if we just start off, we'll do each topic in turn, and then we'll have a couple of Socrative questions before moving on. So the skin, obviously the main things that you need to know about are the inflammatory skin diseases, and then also the skin and soft tissue infection, which overlaps obviously with the microbiology part, and then more about skin tumors as well. So if we just think about what the skin is like, I think a lot of you probably know this, but obviously we're thinking of the skin as being made up of three different layers. So we have epidermis right at the top, and this is really your skin barrier. So this is what's preventing sort of pathogen entry, but also fluid and electrolyte loss and things like this. And it's made up of keratinocytes, and those are essentially epithelial cells. What happens is that they proliferate sort of at the base layer of epidermis, and then they migrate upwards as they differentiate. And right at the top, they basically get rid of their nuclei, and they essentially die off those cells, and they just become a thick layer of keratin, which is the outermost layer of your skin. And then deep underneath the epidermis is the dermis, which is really about your fibrous connective tissue. This contains a lot of extracellular matrix, things like collagen and elastin fibers. Um, and um, and as well as this, the subcutis is below that, and that's really your fat cells, your nerves, your blood vessels. And what you can think of when you think of these different layers is what sort of diseases are most likely to occur there. So obviously in the epidermis, this is the keratin. So you need to think of all those scaly diseases, the diseases that have a thick scale on the top, like psoriasis, eczema, and so on. In the dermis, you need to think of blistering diseases, especially at the epidermal to dermal junction, or right at the bottom of the epidermis. And that's going to give rise to all of your blisters, because you need to actually have fluid building up beneath a layer of skin to have a blister, right? And then if you think of your subcutis, you're going to be thinking of things like erythema nodosum, which is like a paniculitis, so an inflammation of the subcutaneous fat. But we'll go into this in more detail. So this is just an overview of the different kinds of skin lesions that you're likely to encounter, and where they're likely to occur. So really we have the things that are happening in the epidermis, which is all of these cells here that are made up of the keratinocytes. So that's, like SEB-K, your viral warts, where you get infection from your HPV, your different basal carcinomas and squamous carcinomas, and then your pre-malignant lesions like actinic keratosis as well. Right at the bottom, you have your melanocytes, which are actually of neural crest origin. So this is going to give rise to obviously melanomas. Then within your dermis, you need to think of things like dermatofibromas and hemangiomas. So these are kind of benign tumors. And then, of course, you have all of these adnexal structures, which are like hair follicles, sebaceous glands, and so on, that have their own tumors. These are very small print. I wouldn't say you need to know too much about them. Okay, so if we think of our inflammatory skin conditions, first of all, we can kind of divide these into different categories. The first category are your spongiotic dermatitis, which is basically referring to dermatitis, i.e., inflammation of the dermis, right? So inflammation of the dermis and epidermis, that is spongiotic in nature. What that means is there's fluid buildup in the skin. So you basically get swelling in that layer, and so your cells are just a bit further apart, and it literally looks like a sponge, hence the name. So that's all of your different types of dermatitis. So eczema, seborrheic dermatitis, discoid eczema, pomplex eczema, and then your different kinds of contact dermatitis as well. And obviously these can be from both endogenous or exogenous causes. So they can come from within or from outside. Then your psoriasiform types of conditions are things like psoriasis. There's a lot of different types of psoriasis, but obviously we're typically thinking of your plaque psoriasis. That's the one that's most likely to come up. And in this case, your key feature is having elongated reti ridges on histology. So if I just go back to this slide, these little things that are coming into the dermis, these are your reti ridges, and they just get basically longer because in psoriasis, the key thing that's happening is you get extra proliferation of those keratinocytes. So you have a hyperproliferative state. Then you have your vesicular bullous conditions, which are basically blistering conditions. So this is pemphigus vulgaris and bullous pemphigoid. Those are the two that will come up most likely. And then you also have things that happen at the dermoepidermal junction, and that's things like erythema multiforme, Stevens-Johnson syndrome, and also toxic epidermal necrolysis, which you'll need to know about as well. So if we start off with those spongiotic conditions, as I said, these are your different types of dermatitis. So if we think of eczema, which is also known as atopic dermatitis, obviously associated with things like hay fever, which is an allergic rhinitis, and just general atopy. So in eczema, you're having these really pruritic, so itchy erythematous rash, which has crusting and scaling, as I said, because this is happening at the epidermis. And this is mostly found in the flexor surfaces. So in the exam, this is typically going to be talking about happening in the elbow creases or or behind the knees, things like this. However, if it's in an infant, what you might find is that it's originally on the extensor surfaces, so on the back of the elbow and on the knee itself. So that's how you differentiate it. And typically, eczema is more common in children than it is in adults. And if you look at the microscopy, what you end up with is a hyperkeratosis, which is what makes it scaly. So essentially, you get extra proliferation of your keratinocytes and you get excess scale or keratin that's building up on the top. That's what's causing this crusting and scaling. And then you get basically hypergranulosis. So you have more cells that are retaining their nuclei. As I said, they normally shed that nuclei as they go up. And you basically have thickened epidermis with those elongated reti ridges. This is what I was talking about. These are coming down much deeper than they are normally. And you basically get this kind of, and that's really from scratching when it's very severe. So if you think that if you're scratching a lot, you get more inflammation and then you get more proliferation and so on. And so essentially, ultimately, you get lichenified skin, which is kind of like thickened skin. Kind of like a tree bark skin. That's what its etymology is. And you also end up with this lymphocytic infiltrate deeper within the dermis. Then seborrheic dermatitis. This is again a scaly patches and plaques, but in this case, you often find it on the scalp or in your hairline, your face, and then any kind of sebaceous rich areas. So think about sort of on the face, and you will also get it around the nasolabial folds and things like this. This is actually what is causing dandruff, and it's kind of associated with a fungal infection. So that means that your antifungal shampoos and things like that are effective treatments for this. Yeah, so this is basically just affecting those sebaceous areas. So if you find it on those places, then you're going to be thinking more seborrheic dermatitis as opposed to something like eczema. Discoid eczema is essentially eczema. It's just that it's happening in very well-defined coin-shaped areas, essentially, and again, very itchy. And then pomplex eczema is eczema that's happening on sort of the palms of the hands or the soles of the feet. And this tends to be quite vesicular. So you basically have these little vesicles that form on the skin of the palms and the soles, and it's really, really itchy. It's very intensely itchy. So really all of these conditions, itchy, scaly, and erythematous, those are your key features that you're looking out for. Then with your exogenous dermatitis, so allergic versus irritant contact dermatitis are the main ones. And the key thing to differentiate these is that allergic contact dermatitis is exactly what it says. So it's literally an allergy. It's a type 4 hypersensitivity reaction. And that means that you need some type of sensitizing event. So you'll come into contact with whatever that thing is that you're allergic to once, and then the next time you come into contact with it, you develop a hypersensitivity reaction. And after you've been sensitized, it will take around 48 to 72 hours to basically develop that rash. And the common causes are things like nickel, so you'll often get it in response to like a ring or a new piece of jewelry that the person's wearing. Rubber, poison ivy can do it, topical antibiotics, and so on. And in this case, you're getting things like sort of well-defined areas of erythema that are vesiculated and crusting, and they're really itchy, but they're really localized to the areas where you're coming into contact with whatever the thing is that you're allergic to. So that's allergic contact dermatitis. Obviously, you can use patch testing to try and figure out what is the patient allergic to. But in irritant contact dermatitis, this is a little bit different because it's involving having some kind of direct physical or chemical damage to the skin. So think of these irritant contact dermatitis as being essentially a response to something that anyone, no matter who they are, whether they're predisposed to atopy or not, would have a reaction to. So essentially, if all of us washed our hands repeatedly throughout the day, eventually all of us would succumb to some kind of irritant contact dermatitis because you're literally damaging your skin with the chemicals that are in the soaps. So that would be something like a weak reaction that's sort of chronic and it's cumulative. So it's happening over over repeated exposure. If it's a really potent substance like poison ivy, this can mean that you get an acute reaction with a single exposure. So poison ivy is a little bit confusing because it can be both an irritant, but it can also be an allergic contact dermatitis as well. So just be aware of that. But essentially, all of us really would respond to poison ivy to some degree, and that's what makes it an irritant contact dermatitis. This is happening over long-term exposure typically. And so in a question stem, you're often going to hear about occupational history. So they might be a hairdresser, they might be a doctor, a healthcare professional. They might be washing their hands really, really frequently. They might be working in a kitchen or with cleaning products where there's a lot of bleach, for instance, and so on. And so again, this is kind of going to be restricted to the areas that you're exposed to. So hands and web spaces could be a common one that you would have. And generally that skin is going to be really inflamed. So it's going to become really thick, rough, and fissured if it's happening over a long period of time. Then when it comes to the psoriasiform conditions, that obviously this is your different categories of psoriasis. So psoriasis generally is this kind of umbrella term for this chronic autoimmune diseases. They're usually starting to present in teens or early adulthood, and it's got quite a complex pathophysiology. You don't really need to know about it. But the main thing is that essentially, as a result of a lot of different immune sensitizing events and innate immune system activation, you get a lot of hyperproliferation of those keratinocytes, as I said, which is why you get those elongated reti ridges. It's why you get the production of this really thick silvery scale, which is effectively a sheet of keratin, just really, really thick keratin. So the most common one that you're going to be encountering in LabMed is plaque psoriasis. But it's important to know that there are a lot of variants of psoriasis, and this can be, inverse guttate psoriasis, which is normally happening after some kind of infection, like an upper respiratory tract infection, for instance, palmoplantar psoriasis, generalized pustular psoriasis, erythrodermic psoriasis as well. And these ones in bold are sort of your more emergency variants of psoriasis because they're just going to be involving the whole body and they're going to cause significant damage to the epidermal surface barrier. But you don't need to know too much about these for LabMed, I wouldn't say. So plaque psoriasis is really going to have these very, very well-defined silvery scaly plaques on the extensor surfaces. So as I said, elbows, knees are good ones to think about. You may also get arthritis. You may also get nail changes, so nail pitting and onycholysis. So onycholysis is this process where essentially the actual nail plate itself is separating from the nail bed underneath, and it's a painless process, but it's quite typical feature of psoriasis. And often if the patients are going to scratch this scale, or if it's removed, you're going to get all of these pinpoint areas of bleeding, and that's something called Auspitz sign, and that's quite typical of psoriasis as well. And then, as I said, on histology, you get these elongated retiridges, parakeratosis, which basically means you're getting nuclei that are being retained in all of those layers of your keratinocytes. And you get a lot of neutrophil involvement because of all of that innate immune system activation as well. Okay, so the vesicular bullous conditions are predominantly for LabMed split into bullous pemphigoid and pemphigus vulgaris. And these ones always come up. And no matter what you do, you will always see that both of them are going to be one of your answers in the MCQ. So you really need to know the difference between these two. Otherwise, it'll be impossible to answer that question. So bullous pemphigoid, what I want you to remember is that bullous literally means like a blister, right? So with bullous pemphigoid, you're going to get blisters. You get it in both, but the difference is that with bullous pemphigoid, you get these really tense, intact, fluid-filled blisters. And it's really your most common autoimmune blistering disorder, and it's typically going to be seen in your older adults. You're going to be getting this kind of response to hemidesmosomal antigens. So that's typically BPAG1 and 2. And what they're doing is they attach your epithelium to the underlying basement membrane. So at this point, what you're getting is essentially a separation between that epithelium and the basement membrane. So the fluid builds up underneath the epithelium, and the epithelium holds it in place. So because of that, you get these tense fluid-filled blisters, and they don't tend to burst. You're going to find it on flexor surfaces, the thigh, the abdomen, and sometimes in the mucosa, so things like the mouth, but this is much more rare. And ultimately, if you were to do some kind of histology, what you would find is deposition of IgG and C3 along the basement membrane, because that's where the hemidesmosomes are. Okay, in contrast, pemphigus vulgaris is actually a really uncommon condition, and it tends to be in more like middle age. What you find is that it's in your desmosomal antigens, so desmogliin 1 and 3, and these are actually causing adhesion between the different suprabasal cells in the epithelium, i.e. the epidermis itself, right? So they're allowing the cells to adhere to one another. And so as a result, when you do histology on patients who have pemphigus vulgaris, you'll see this chicken wire appearance on histology. That's very classical in a question stem. And it's because you get IgG and C3 depositing between the cells, so intracellular, and so you literally get this chicken wire pattern. And because it's in the epidermis itself, there's nothing to hold the blister in, if you know what I mean, because it's literally in that top layer. And so the blisters are really, really prone to bursting. They're quite flaccid, and they tend to affect more of your mucosal surfaces. So your oral mucosa, the esophagus, the conjunctiva, and also you get sort of skin blisters as well. And they would frequently erode and leave this more like ulcerated appearance as well. So hopefully that makes sense. Okay. Then when we talk about interface conditions, this is really things like erythema multiforme, which is going to be your symmetrical targetoid lesions. So targetoid lesions, because they literally look like they have this bullseye appearance. So you have a red ring, then you have this pale center, and then right in the middle, you have another red dot as well. So literally looks like a target. It normally is going to start on the extremity. So it's going to start on your hands and feet. And it tends to be after infections like HSV or sometimes drug reactions. So things like penicillins and sulfonamides can cause this. And ultimately what you see is some kind of lymphocytic infiltrate if you do histology. Then the other ones to really know are Stevens-Johnson syndrome and toxic epidermal necrolysis. Now, these two exist on a spectrum. You can think of them as existing on a spectrum. So essentially, they tend to be associated with drugs. So things like allopurinol, again, antibiotics, anticonvulsants, and very rarely with infection. But in this case, the onset is kind of a couple of days or months after they've started taking that drug. And then what happens is they get this sort of flu-like prodrome. So they'll feel like a bit of, just being a bit under the weather, some malaise. And then suddenly they get this onset of rash. And typically there's going to be mucosal involvement. So it's going to affect the mouth and so on. Now, the difference between the two is that if you have Stevens-Johnson syndrome, you're typically thinking that there's around 10 to 30% of the body area that's involved. So you don't really have that much involvement of your skin. However, if it's a toxic epidermal necrolysis, you essentially have more than 30% of the body surface area affected. So it's much more extensive, and this one can be life-threatening. Obviously, both of them mean that they're disrupting the epidermal barrier, so you have loss of water, and you essentially have a reduction in your skin barrier. And so you become much more prone to life-threatening infection as well. So what are we talking about here? Erythema multiforme, think about it if they've had an infection, something like HSV in the past, they have these targetoid lesions, they're really on the extremities. SJS and TEN, think about them more when you have patients who've been taking a new antibiotic, especially something like gentamicin, for instance. They then develop this kind of flu-like illness plus a rash. And then now, if it's around 10 to 30% of the body area, that's Stevens-Johnson syndrome, more than 30%, it's toxic epidermal necrolysis. Hopefully that makes sense. And then obviously, I think the term erythema gets thrown around a lot. There's a lot of different dermatological conditions that use this in the name because, redness of the skin is very, very common. Essentially, if we talk about erythema as a standalone term, that's just talking about the skin being a bit more red because you have capillary dilation. If we talk about something like erythroderma, this is essentially when we have erythema, but it's very generalized and you get scaling, and now you're affecting more than 90% of the body surface area. And this is often due to one of these underlying conditions that we've spoken about, eczema, psoriasis, drugs, malignancy, and this is a dermatological emergency. So something like this top picture here, it's because essentially your entire skin barrier is affected, and so you're very, very prone to essentially hypothermia, you're losing all your water and your electrolytes, and so you're very prone to dehydration and can be life-threatening. Erythema multiforme, we've gone over. This is these targetoid lesions, typically due to infections like HSV. Erythema nodosum, this is again this redness that you have, but it's typically on the shins, and it's because of a inflammation of the subcutaneous fat. It's what we call a panniculitis. This is often associated with conditions like IBD, also sarcoidosis, and so on. So these are these tender nodules, so they'll actually be very tender to touch as well. And then you have erythema migrans, which is a little bit similar to erythema multiforme in the sense that it also has these kind of like bullseye appearance, but you can see they're a little bit different because these are a bit larger and they tend to just be a single lesion where you've been bitten by a tick, because this is very characteristic of Lyme disease. And typically it's going to be sort of wherever that bite is. So it's not really limited to the hands and feet, if that makes sense. Okay. And then finally, you have things like drug reactions. You can have a fixed drug reaction, which is occurring kind of very shortly after, within hours after you've had that drug. It will come back again at the exact same site if that drug is taken again. So this is a type 4 hypersensitivity reaction. And you'll typically get these kind of erythematous or brown plaques that are commonly on the face, the lips, buttocks, genitals, trunk. Yeah, you can see it on the back. And it can take up to weeks to months until the rash goes away, even if that drug is stopped. So it can be quite longer lasting, if that makes sense. And then, of course, urticaria, which is very, very characteristic of your type 1 hypersensitivity reaction. So this is where you get those wheals, which are basically those fluid-filled raised bumps that are extremely itchy because of all of that histamine that's being released. Okay, so that's all about the inflammatory diseases. Now we move on to the infections. So generally, when we're talking about skin and soft tissue infections, you're going to be thinking about treating the patient with flucloxacillin if it's a staph infection, because remember that for Staph aureus, we need to use flucloxacillin just because the structure of that antibiotic means that Staph aureus is sensitive, whereas strep is much more easily treatable with your typical penicillins like amoxicillin, which is very, very narrow spectrum and perfect for strep. So if we're confident that it's staph, give fluclox. If you're confident it's strep, give amoxicillin. If you don't know if it's either, you would give flucloxacillin because that will cover you for both. And typically you can think of your infections as being limited depending on the site of the skin that we're talking about. So If we have a very shallow infection, so it's just affecting the epidermis, we can think of things like impetigo. If it's affecting the hair follicle, you can obviously get a folliculitis. If it's a bit deeper within the epidermis and dermis, we're thinking of, first of all, erysipelas. And then deeper than that will be cellulitis. And then deeper than that will be necrotizing fasciitis or neck fash, which is your one that you must never miss, basically. And you can see the different common organisms that we're dealing with in each of these areas. So if we start off with those very superficial ones, we're talking about things like impetigo, folliculitis, and erysipelas. So impetigo is what you're typically going to be seeing in children, especially if they've been in nursery, because it's really, really infectious. So if one kid gets it, they're all going to get it. And the very, very classical description in a question stem is about golden crusting around the mouth and the cheeks. And that pretty much is pathognomonic for a Staph aureus infection. But sometimes it can also be a group A strep, so strep pyogenes as well. These are quite purulent lesions, so there will be some pus as well. And ultimately, what you need to do is that the children must stay at home until all of their lesions have crusted over, or for at least 48 hours after they've started taking antibiotics, because otherwise they're just going to infect everyone else. Then you have folliculitis, which, as I said, is inflammation or infection of the hair follicle, and this can ultimately lead to a boil or a furuncle if it becomes larger. So typically, patients will get this after shaving or exfoliation, commonly due to Staph aureus, or if they've been in a spa, they've been to a hotel, some kind of things. They can get whirlpool folliculitis, which is classically Pseudomonas infection. Obviously, remember your antibiotics for Pseudomonas. There's 5 antibiotics. You must know them. I hope they went over those in microbio, but things like meropenem, ceftazidime, and so on. So these are your these folliculitis infections are self-limiting, and essentially, if they keep getting them and there's no obvious trigger, you might want to consider testing for HIV. Then erysipelas, as I said, this is really in the superficial dermis or the deep epidermis. And this is kind of like, what you can think of it as being a superficial form of cellulitis. So I think everyone knows cellulitis because they drill it into your brain. Erysipelas is effectively that, but just a tiny bit higher up in the skin. And you're going to get this fiery red, tender, painful plaque, which has a very well demarcated edge. So it's very defined where it starts and where it stops. And essentially you can get it on the legs or the cheeks. But in this case, compared to your malar rash, which you see with lupus, you'll find that your nasolabial folds are not spared because it's not the same pathophysiology in this case. And this is typically strep pyogenes or group A strep. The important thing to remember is, while it might be important for LabMed to distinguish erysipelas from cellulitis in terms of the question stem, from a clinical point of view, it's actually not that important if you think it's erysipelas or cellulitis. It doesn't matter if you mix them up. The important thing is that you would treat with flucloxacillin, because even though erysipelas tends to be strep, you would only treat it with amoxicillin if you're confident that it's erysipelas, not cellulitis, because as we'll come on to, cellulitis is much more likely to be caused by Staph aureus as well. So you would want to cover for that as well. So cellulitis tends to be much more rapidly spreading inflammation. Now we're in the deep dermis and maybe a bit of your subcutaneous fat as well. You get redness and pain, and then you might also have some signs of systemic illness. It's usually caused by strep pyogenes, as we've said, but sometimes it's caused by Staph aureus, sometimes it can be Haemophilus as well. And you would give flucloxacillin to try and get on top of that. And obviously, if you're pen allergic, you would substitute. I think it's erythromycin is second line. Neck fash is obviously your one that you must never miss. And how you're going to know it's neck fash is that you're going to have severe pain that's disproportionate to your clinical signs. So the patient might look like they're not that badly infected. They might look like this, but they're going to tell you, I'm in so much pain. And the main reason why we care about this, because it's what people colloquially refer to as like a flesh-eating bug. It's really rapidly progressive. It's life-threatening. You have infection of that deep fascia and subcutaneous tissue. So it's really, really quite deep in the skin. And you're going to be thinking about this if they're diabetic, if they're immunocompromised, have classic risk factors, maybe they've had recent abdominal surgery, or recent infection of the perineum or perineal trauma, like in childbirth. Going to be caused by things like group A strep, Pseudomonas, and essentially you'll have really, really significant pain and they're not going to be responding to antibiotic therapy. Why? Because in this case, the definitive treatment for neck fash is surgical debridement. So you really need to get plastics involved and they're going to need to do this. And that debridement will need to be repeated if the infection is still not controlled. You also do need to give IV Coamox and clindamycin plus vancomycin if they test positive for MRSA, because ultimately you do need to get on top of the infection as a whole. And just to note that there is a specific type of neck fash, which is called Fournier's gangrene, and that's essentially when you have neck fash that's affecting the perineum and the external genitalia, so scrotum, and so on. And that's another one that you must never miss. And in that case, you would obviously involve urology as well. Okay, so other infections that you might need to know about are things like toxic shock syndrome. So this is this systemic response that's occurring after release of the TSST1 toxin by Staph aureus, and also you can get it with strep pyogenes. Typically, we're thinking about this in patients who have a fever, they have a rash, they're getting desquamation, so the skin is literally peeling off. And this is happening kind of a couple weeks after they get that rash. They are very hypotensive and they have multi-system involvement. So basically 3 or more organ systems need to be involved. Staphylococcal scalded skin syndrome, also called Ritter disease. This is more common in your neonates and your young children. It's like a superficial blistering skin disorder caused by exfoliative toxins. And these are targeting desmoglein 1. So you can think of this as being a bit similar in presentation to your pemphigus vulgaris. And you manage this with Fluclox. And then gas gangrene, this is essentially where you get gas in the muscle because the muscle is undergoing necrosis. So this is typically caused by Clostridium perfringens. So this is why it's called clostridial myonecrosis. So patients are obviously going to be very unwell and they need as well emergency surgical debridement and antibiotic therapy. Okay, skin and soft tissue infections from fungi and parasites. We need to think about things like ringworm. If it's on the foot, we're thinking athlete's foot. On the scalp, you want to think about tinea capitis, which can cause alopecia. So if you have a patch of hair loss, you might be thinking they might have ringworm, and they tend to have these raised red rings. Scabies tends to be caused by a mite. This is when they're going to get a lot of intense itching, and it tends to be in between the finger, the interdigital spaces, so in between the fingers. And you can actually see the track marks of the mites burrowing if you look under the microscope. Normally, you manage this with 5% permethrin cream on day 1, and then again on day 7, because you can only kill them once they hatch. You can't actually get rid of the eggs themselves. So that's why you space out that treatment like that. And you need to treat close contacts as well because it's very, very infectious. Okay, so that's everything to do with infections. Now moving on to the tumor part. So this is just kind of for your revision. If you're ever kind of wondering how the terminology works in derm, typically when we're talking about lesions, we can split them in based on size. So whether they're smaller or larger, and then whether they're flat or elevated, and that's going to change essentially what they're called. So, macules and papules are your flat and elevated small lesions. Once they become larger, you think of patches and nodules. Then you have your plaque, which is essentially a flat lesion that has a bit of induration, a bit of elevation, usually more than 10 millimeters. So like in psoriasis, for instance. Then you have your sort of blistering fluid-filled areas, which can be either a vesicle, which is basically when it's less than 10 millimeters, or a bulla when it's more than 10 millimeters in size. So those are kind of like your different blisters that you can get. So when we think about skin lesions, we can think about the ones that are benign and then the ones that are obviously malignant. So in terms of the benign skin lesions, the ones you need to know about is probably seborrheic keratosis. So this is different than seborrheic dermatitis. I know it's confusing. Just be aware of that terminology. Seborrheic keratosis is very, very common. You see it in a lot of individuals, very slow growing, tend to be single or multiple. The question stem's normally going to say that they are greasy or warty in appearance. They have a stuck-on appearance. It looks like somebody's just come and stuck it on the face, and they're papules or nodules, so they're elevated off the skin. In terms of microscopy, they are often pigmented. The differential for seborrheic keratosis would be a melanoma. That's what a lot of patients will be worried about, but they're quite distinct on histology. And they're very, very benign. So they would normally persist unless they're removed, but there's not any real indication for removing them because they're nothing to worry about. Then you have your viral warts. These are very common, especially on hands and feet, typically caused by HPV infection. Remember, these are your low-risk forms of HPV, like 6 and 11. They tend to be papules that have a rough surface. They're sometimes flat and they're sometimes filiform, which is like this, right? They have this kind of appearance here. And in microscopy, you're going to see a lot of proliferation of those keratinocytes, hypergranulosis, so a bit more blue, and also papillomatosis, so you look like a papilloma, if you know what I mean. And these typically will disappear spontaneously on their own, but normally patients are also going to be treating them with like over-the-counter therapies or even cryotherapy if they want them removed. And then you have this thing which is called keratoacanthoma. So this often resembles a squamous cell carcinoma, which is why we worry about it. Typically seen in males, typically sun-exposed sites, and they grow quite quickly. If you look at the macroscopic appearance, it's a very dome-shaped, flesh-colored lesion, and it has this central keratin-filled crater. It looks very, very similar to a well-differentiated SCC. But the thing is that these will often spontaneously regress, so they will often disappear on their own. But the thing is that in practice, a lot of SCCs can look like this, and so you will find that a lot of patients will get them excised because we just can't be sure until we look at the histology that they're definitely a keratoacanthoma and not a SCC. But for LabMed, if you see this kind of dome-shaped, flesh-colored lesion, central keratin-filled crater, typically it's going to be a keratoacanthoma. Okay, so SCCs, we can think of these as being kind of on a spectrum. So we start off with our pre-malignant lesion, which is actinic keratosis, and right on the other end, we have our invasive SCC. So these are all occurring in sun-exposed, pale-skinned individuals. So you see them more in the elderly, so after decades of sun exposure. If we start off with actinic keratosis, this is entirely benign, but sometimes it can develop into invasive SCC. And you get these scaly macules, so they're flat typically. You can also get papules or plaques, which can be a bit elevated, and they have surrounding erythema. So it's a lesion that has a bit of redness around it. And sometimes you have these projections or these horns, which are from keratin. Then once your actinic keratosis has extended to cover the full epidermis, so the full top layer of the skin, then we're talking about in situ SCC or Bowen's disease. In this case, again, it's still benign, but it has malignant potential, so it's still pre-malignant. The thing that differentiates Bowen's disease from SCC is that your basement membrane is intact, so the cells have not gone past that basement membrane. However, you do have full thickness dysplasia on histology. It tends to be a bit more red and scaly than your mild or moderately dysplastic actinic keratosis, but it can be quite difficult to distinguish clinically. Then you move on to your invasive SCC. In this case, like all SCCs, which you've hopefully learnt about in the lung and so on, they're going to be distinguished by these keratin whorls, these intercellular bridges on histology. They're going to be scaly, keratotic, nodules, plaques, or ulcers. As I said, they can look a little bit like their keratoacanthoma. They're malignant. And obviously the stage is dependent on the thickness of the tumor, the depth of invasion, and the spread. They typically metastasize to local lymph nodes and distant sites, but it's rare. So if they metastasize, that's where they'll go, but they don't often metastasize that widely or that quickly. Then we have our BCCs, basal cell carcinoma. So basal cell carcinoma, we're thinking of the basal cells of the epidermis, right? So basal layer of cells, again, it's driven by the keratinocytes just at the bottom layer of the epidermis. It's the most common malignant tumor of the skin, and it's presenting in sort of middle to old age. these are extremely slow growing lesions. So you're never going to think about BCC if the patient's like 20 years old. It just doesn't happen. They almost never metastasize, and they are very, very safe to excise with long waiting lists, because you'll see a patient today and then in a year's time, and it looks exactly the same. It's very slow growing. The reason we care is that it can be locally destructive, especially if it's in the head and neck region. So you can see this one here that's by the eye. That would be that patient would be at danger of losing their eyesight because it can invade further into the eye socket. So that's why we'd care about it. You would know it's a BCC because it's going to be called a pearly raised nodule, and it has arborizing, so branching like a tree, telangiectasia. These are these blood vessels. So these kind of you can see it best here, these little blood vessels kind of threaded through the lesion. And this means this is definitely a BCC. That's essentially pathognomonic for BCC. Occasionally you get plaques, sometimes you get ulcers as well, and sometimes they can be pigmented. So like this one here, which might resemble a melanoma. Okay, so the last one for the skin lesions is melanoma. Obviously, this one is the most dangerous. We have, again, a number of different lesions here. You have benign nevi, dysplastic nevi, and then melanoma. The important thing to remember is, unlike SCC, melanoma does not actually normally arise from benign nevi. It actually tends to arise from de novo lesions that form. So it's not, if you have a lot of, moles, they're not necessarily destined to become melanoma. Whereas with SCC, actinic keratosis and in situ SCC are much more likely to progress to SCC, if that makes sense. So benign nevi are just like your moles. The most common one would be your common acquired melanocytic nevus, which looks something like this. You can get different types depending on where they are. So you can have junctional, compound, intradermal, not that necessary to know the different types. Typically, these arise pretty young, and they very rarely become malignant. They will be negative for your ABCDE criteria, which we'll go through in a second. And microscopically, you'll see proliferation of those melanocytes in nests. So you do get a bunch of melanocytes that have basically divided in a single area. Then you have dysplastic nevi, which are more in, again, teenage and adulthood. They have some features that would be characteristic of melanoma. So some of the ABCDE criteria are met, but in this case, they're mostly stable or they regress, and they very rarely become malignant. So these ones, if you have dysplastic nevi, you can think this patient might be at risk of developing melanoma because they're starting to get dysplastic nevi. But those nevi themselves are not necessarily going to be the ones that become melanoma, if that makes sense. Malignant melanoma is when you have your ABCDE criteria are positive, and that's when obviously we need to worry. So essentially, when a patient comes in with a pigmented lesion, you want to be asking them about the ABCDE criteria, asymmetry. So, is it symmetrical? If it's symmetrical, it's very reassuring. What about the borders? If the borders are irregular or blurry, it's worrying. What are the colors? If there's 2 or more colors, you want to start worrying. What about the diameter? So if it's more than 6 millimeters, that's worrying. And then you want to think about evolution and elevation. So if that lesion is changing in size, in shape, in color, or maybe it's becoming raised where it was flat before, then you're worrying. Ultimately, prognosis for melanoma is based on Breslow thickness, which is really the thickness at which the melanoma is kind of penetrating downwards. So if it's less than 1 millimeter thickness, your survival is very good. But if it's more than 4 millimeters, you have a very poor 5-year survival. You have other prognostic features, age, sex, site. So obviously it's worse in sites like so it's better if it's kind of in your arms and legs because you're much more likely to pick it up. If it's on your back, it's much worse. And that's tend to be related to the fact that you notice it later. It's worse in men, and it's worse in the elderly. And obviously what you want to remember is that a lot of melanomas are linked with mutations in BRAF, and it's important to test for that genetically because there are targeted therapies that we can use, like BRAF inhibitors. And it can metastasize both to lymph nodes and also hematogenously. So there's different types of melanoma. The one that you're going to be thinking of seeing most frequently is superficial spreading melanoma. It is found in your fairer skinned individuals, so classified as the Fitzpatrick skin types 1 and 2. Much more common in the truncal areas in men and in legs in females. You can think of this as just being the fact that it's to do with sun exposure as well. But this is intermittent sun exposure. So truncal in men, because when it's sunny outside, they're much more likely to take their tops off. That's why you're much more likely to get intermittent sun exposure. Whereas legs in females, same reason, they're just going to wear shorter skirts and so on. Sorry, that's a bit gender stereotype, but hopefully it'll help you remember it. Nodular melanoma, this has much more rapid invasion downwards, but it doesn't tend to grow outwards much. So obviously, if it's going down, it's going to be much more likely to ulcerate and to bleed because it gets to the blood vessels. Then you have a lentigo maligna melanoma, which is in elderly patients, chronically sun-exposed skin. And then acral lentiginous melanoma is not associated with sun exposure. This is the one that you see in your nails, in your palms, in your soles, and you can often see it in darker skin tones. So acral lentiginous melanoma is actually the one that Bob Marley had. If you guys, I don't know if you guys are aware of that, but essentially that's the cancer that he had, and I think it was his big toe. So that's how I remember acral lentiginous melanoma, and it's quite severe. Okay, so let's do a couple of Socratives. Hopefully this is working. Obviously, if anyone has any questions, please do interrupt me. Okay. Are you guys all right for me if so just for ease, I won't share my screen with the answers, but it should come up on your devices when I share the answers. I'll still go through them all, but just tell me if that's not working for you and I will share my screen as well. Okay, so I think most of you have answered. So we're talking about tense blistering lesions. Perfect. So bullous pemphigoid. That is exactly right. As I said, tense blisters, we're thinking of bullous. Bullous means blister. So you're going to get these tense blisters. It's going to be, if anyone wants to pop it in the chat, what is it targeting? If you can remind me, what is the bullous pemphigoid normally targeting? Hopefully you remember. You don't have to if you don't want to interact. But anyway, I'll tell you. Yes, perfect. Hemidesmosomal antigen. So that's BPAG1 and BPAG2, different from pemphigus vulgaris, which is your desmosomes, desmoglion 1 and desmoglion 3. Someone's put epidermolysis bullosa. Don't worry about this one. This is a very rare genetic condition. It is true that it is a blistering condition, but it's a little bit different because it actually kind of epidermolysis. If you wanted to know for exam technique, you could work this out. So epidermolysis basically means like lysis of the epidermis. So essentially the epidermis is kind of all dying away, and it's so you're essentially shedding all of that top layer of skin, and it's a blistering condition, but you lose your entire skin barrier. It's very it's a very dangerous condition, quite life-threatening. They recently did manage to regenerate an entire skin of like a 12-year-old boy, I think about 5 years ago, 6 years ago. If you guys are interested in, you can look at the news about that. It was really cool. With stem cell therapy. Okay, second question. Oh, sorry, my Socrative has logged me out. Sorry, can you guys just re-log in? It has logged me out for some reason. I will skip to the second question. Okay, I think everyone's there. Okay, so I'm just can you guys see this question on your Socrative? Yes, okay, people are answering. It's good. Um, so I might have to move a bit quicker, otherwise we're never gonna get through breast and gynaes. So if you guys don't mind. So yes, this is scabies. How do we know it's scabies? These are very, very itchy, and it's between the finger spaces. So and it's particularly bad at night. So this is quite characteristic of scabies, as opposed to your other ones. I can see you're thinking of occupational history, which is good. But the linear lesions are very, very, very characteristic of those scabies burrows, which tend to be they tend to burrow in kind of a straight line. Prognostic marker of melanoma is the next one. Hopefully you guys are going to get that. Perfect. Depth of melanoma. So melanoma prognosis in terms of the prognosis. So if your patient's sitting in front of you and say, how is my survival going to look like in the next 5 years? It's all about Breslow thickness. Okay. This is the depth of the melanoma, how deep it's gone into the skin, because that's going to tell you how likely it is to have spread elsewhere. All right. Number of episodes of sunburn. I mean, this is relevant in terms of the risk of getting melanoma, but not in terms of the prognosis of melanoma once you've been diagnosed. Okay, so this one is urticaria. I can see a couple of people have gone for erythema multiforme. I'm just zooming into the picture. So erythema multiforme would be more targetoid lesions. As I said, those ones that have a bullseye appearance typically starts on the hands and feet. Okay, this is on the back, not the hands and feet. So I'm already leaning away from erythema multiforme just on the picture. Um, Also, it's quite raised. So obviously this looks more like an urticaria. He works as a gardener, so obviously that's a risk factor for coming into contact with a lot of things that he might be allergic to. And this is more like a hypersensitivity reaction, histamine mediated, very, very itchy. Erythema multiforme is nowhere near as itchy as urticaria. Okay, just a couple more. Okay, so sore and itchy skin on the hands and wrists, getting better when not in work. So this is a clear occupational history, coming into contact with something, all right? So what is the test that we're going to use? Patch testing, exactly. Patch testing is the one where you're putting on a patch and then you're waiting to read the response like 7 days later. So it's for delayed hypersensitivity reactions. Skin prick is when you're literally doing a little prick in the skin and you're putting in the allergen and you get a readout immediately. So that's for your type 1 or immediate hypersensitivity reactions, okay? Um, this seems like it could either be an allergic contact dermatitis, in which case patch testing would be helpful. If it's an irritant contact dermatitis, where occupational history is also important, patch testing is unlikely to be helpful because it's not about an allergy being present, right, or a hypersensitivity reaction. It's about the fact that you're constantly damaging the skin with repeated hand washing, for instance, with soap and water. So you're not allergic to soap, but you're just stripping away that skin barrier from repetitive hand washing. Okay, final one for this, and then we'll move on. Yes, perfect. This is a BCC. How do we know this is BCC? First of all, the keywords in the stem. It is rolled, so the outside is kind of rolled. It's got a rolled edge. It contains telangiectasia. Those are those kind of tiny little blood vessels that are sort of arborizing or branching. It doesn't say that here, but that's characteristic of BCC. The other reason we know this, it's round, it's raised, and it's flesh colored. Those are all characteristic of basal cell carcinoma. Actinic keratosis, this is your actinic keratosis is more about being related to sun exposure, and it's related to SCC. It tends to have surrounding erythema. So you'll have some change that's scaly because it's epidermis, SCC, and it's going to be surrounded by erythema, so some redness. If it was molluscum contagiosum, so that is an infection. Molluscum is normally giving, it is round and it is raised normally, but the key feature of molluscum is that it has essentially a belly button in the middle. It's called an umbilicated lesion. So it's basically a round raised lesion. Looks a bit like a BCC, but with a belly button in the middle. Okay. All right, let's continue, guys. We'll move on to breast quickly. I think that breast is one very, very long lecture. I don't know if it's the same for you guys, but there was a lot of stuff that was covered. I've just tried to summarize it so you can really, really pick out the key differences in the presentation. So I've just made tables for you, and I hope that this is going to be useful for your revision. But let's go through it. So really what we need to know is about the common things that patients are going to present with, which is like a breast lump, as well as like skin changes, discharge, and so on. And then you want to know which of these are benign, which of these are malignant, and what do we do about that? So this is really for your revision later, but you can kind of differentiate your different diagnoses based on kind of going through this checklist. So you can think about your breast lumps. Are they tender? Are they non-tender? Are they firm? Are they mobile? Are they tethered? Is there skin change, etc.? So you can go through this when you're revising later. But what I've done is I've kind of categorized it into your different types of breast diseases, okay? So these ones are your benign inflammatory breast diseases. And these are the key ones that you need to know about. So the first one's mastitis. I think this is the one that people are most familiar with, maybe. Mastitis obviously is inflammation of the breast. This tends to happen in response to lactation, so breastfeeding, and often it is unilateral, although you can get it in both breasts, but it might be that they kind of get mastitis at different times, if that makes sense. It's very tender because obviously it's inflamed, it's warm, there's some focal erythema, and they might even be systemically unwell if it is quite a severe infection. So you need to check your sepsis red flags. Major risk factor is milk stasis. So you really don't want them to stop breastfeeding. The treatment is to continue breastfeeding because if you leave the milk static in the ducts, it's obviously prone to infection. So that's going to exacerbate the symptoms. If it is infected, which is not always, sometimes it's just inflamed, but if it's infected, it tends to be Staph aureus. So if you needed antibiotics, you would give flucloxacillin normally. Typically, this is a clinical diagnosis. If you suspect that there's an abscess underlying the mastitis, then you might consider an ultrasound, and then you might be thinking about incision and drainage. But this is often not needed. Sometimes you can do microscopy cultures and sensitivities of the milk itself if they're getting severe infections or if it's recurrent. Then we have fat necrosis. This is typically when patients are presenting with kind of a painless, firm, irregular, non-mobile mass, and it's associated with skin puckering. So what's happening is that essentially it's often caused by some kind of trauma, and that trauma history is really important because it almost clinches the diagnosis for you, especially in a question stem. What's going to happen is that the trauma is going to cause some kind of adipocyte, so fat cell necrosis. So those fat cells are going to die. It's going to cause inflammation, and then you get fibrosis in that area because of all the inflammatory cells. And so you get some kind of scar tissue depositing there. This can be from very minor trauma. So even if they're wearing a seatbelt and they're involved in a car accident and the seatbelt kind of digs in, that can be enough to cause fat necrosis. And they can also get it after radiotherapy, surgery, etc. You might want to do ultrasound, mammogram, and you might see this kind of calcified mass. The histology is what's going to tell you it's definitely fat necrosis. It's going to have foamy macrophages, giant cells, normally damaged adipocytes, fibrosis, and dystrophic calcification. And normally there's not really much that needs to be doing in terms of management, but obviously your key differential here is breast carcinoma, so just beware that you're not missing breast cancer. Duct ectasia, this is very, very common around the menopause. So think about it if you have perimenopausal women. Why? Because it's about hormonal changes. Hormonal changes are happening all over the body. That means this is bilateral, okay? It's in both breasts at the same time. And it tends to be a subareolar lump, so underneath kind of the areolar region. And often you'll see them reporting some kind of green, cheesy nipple discharge. The reason that you get duct ectasia is because with age, the ducts will weaken and like kind of the dilate out, they widen, and then they basically get blocked by cellular debris, and that causes inflammation and that causes nipple discharge. So you also often see it in smokers. That's the other very key risk factor here. And again, smoking affects the whole body, so it's going to affect both breasts. You will see these dilated ducts on biopsy. And you'll see kind of this granular necrotic debris that I was talking about. Again, conservative management if it's mild. You could consider surgical excision of those ducts if it's very severe. Then you have something called fibrocystic change, or otherwise known as fibroadenosis. This is very, very confusing. It's not the same as fibroadenoma, which we're coming to. It's just that these terms are used interchangeably. And there's even another term, which I think is like benign mammary dysplasia. Very confusing. In LabMed, if I'm remembering correctly, they almost always use the term fibrocystic change. So maybe for now, forget about fibroadenosis, but it might come back up again in the AKT at the end of 4th year. Just FYI. This is more your middle-aged women. It's a very, very common cause of like lumpy, tender breasts. The size and the tenderness can fluctuate with the menstrual cycle. And again, because it's to do with hormonal changes, it's bilateral, symmetrical, and they might have cysts, as in the name, fibrocystic change. So often what you're going to see is that you have connective tissue, ducts, and lobules that undergo fibrosis and then cystic dilation in response to your hormonal changes. And then on mammogram, you get these dense cystic breast tissue. There is a risk of neoplasia if it's atypical hyperplasia, but this risk is not really seen in the majority of patients, only if it's atypical, okay? Supportive measures like NSAIDs and warm compresses tend to be your management, cyst aspiration if it's large and painful. And if there's some kind of atypia present, then you'd consider follow-up. Then your radial scar or complex sclerosing lesion, this is in your 40 to 60-year-olds. Often this is asymptomatic. So if someone's coming in with some kind of symptom, don't think about this. It's not going to be your diagnosis, okay? It tends to be picked up incidentally when you're investigating for something else. And it's normally a star-shaped or a stellate lesion that you see on mammogram. It has this kind of central fibroelastic core with entrapped and proliferating benign glands that radiate outwards. So they literally form this star pattern. There is a small risk of cancer associated with it. And so you will normally excise it to rule out any kind of malignancy. Okay, so those are your benign ones. Now let's talk about the fibroepithelial neoplasms of the breast. Okay, these are neoplasms, so abnormal growths. They're fibroepithelial, so they're fibrous, as in your connective tissue and your epithelium, okay? 2 tissue types. So the benign one is fibroadenoma. This is very, very common, often see it in the under 30s. These patients often have a discrete, non-tender, highly mobile lump. It's often called a breast mouse because it moves around very, very easily underneath the breast on examination. It's very smooth and it's well circumscribed. Mouse, think about the mouse of a PC, not a mouse like the animal. Okay, the pathophysiology, what you're going to be hearing about is that this has both epithelial and stromal, so fibrostromal, interchangeable, right? Proliferation. Present in women of reproductive age, and then often they're going to regress post-menopause. They're completely benign. They're not pre-malignant. They're not associated with carcinoma. And essentially, you will get this biphasic histology. So you have both epithelial and stromal proliferation, and you might have some calcification. You're just going to observe if they're small and they're asymptomatic. If they're very large or they're growing or they're symptomatic, you could consider surgery, but it's not really that necessary. Then the one you need to worry about is the phylloides tumor. This is in older women. The main thing is that this has an older age of onset. Firm, mobile, non-tender, well-circumscribed mass that can ulcerate. Again, it's a mixed epithelial and stromal tumor, so it's exactly the same as fibroadenoma in that sense. But in this case, it can be benign, or it can be locally aggressive, or it can be malignant. So it can progress all the way to a sarcoma. What you get is stromal overgrowth. So the fibrous part overgrows, and then you get hypercellularity. You have way too many cells, and then it progresses towards the sarcoma. So your biopsy will show that stromal hypercellularity. You might get pleomorphism and mitoses, which are your classical signs of malignancy. And then if it spreads metastatically, it's pretty much always through the bloodstream, okay? And it tends to go to the lung. So phylloides tumors are a pain to deal with because if you excise them and you don't take a wide enough margin, they just come back again. So you really need to do a very wide local excision. That's like a centimeter of margin between where it ends and the normal tissue. And if it's very large, you might even need to do a mastectomy. And then you basically follow them up for recurrence as well. Okay, so those are your fibroepithelial neoplasms. These are your epithelial neoplasms. We're just talking about the epithelial part. You obviously have your intraductal papillomas. So these are your benign lesions. These are unilateral. They're typically presenting with bloody nipple discharge, sometimes serous as well, so kind of watery, and like mucousy. Can present as a mass if it's very large, and your main differential, because of the bloody discharge, is breast cancer. But as I said, these are benign. What you have is your proliferation of your epithelial and your myoepithelial cells, and then a fibrovascular core. So how are you going to know it's this and not breast cancer? Is the presence of these myoepithelial cells. So the myoepithelial cells are kind of like right next to the epithelial cells in the normal breast tissue. So if you have them and that relationship's preserved, this means that it's a benign lesion. And these are common in your premenopausal women. Obviously, you want to do your full imaging and so on to look for breast cancer and exclude that. Then you have your ductal carcinoma in situ. So this is DCIS. This is, again, pretty much asymptomatic. You're not going to pick this up. Only in a very few rare number of cases, you might get some signs and symptoms. And this might be because they have Paget's disease, which we're coming on to in a second. If you have DCIS, you basically have intraductal epithelial proliferation. But in this case, you have some sort of cellular atypia, but it's not yet invaded the basement membrane because it's in situ, right? So it hasn't yet gone through that membrane and become invasive. So this is still kind of pre-malignant, okay? It can progress to invasive carcinoma, but it doesn't necessarily do that. So some people will be fine, but you have a 30% risk that it will progress in a 10-year period. So ultimately, we tend to excise these if they're detected. But as I say, you're going to rarely pick these up in clinical practice. Paget's disease of the nipple. So this is effectively when your DCIS has actually spread through the duct. So imagine it grows along the duct, not invaded through the basement membrane, right? It's grown along the duct all the way to the nipple or the areolar region. And now it starts to involve the epidermis of the nipple. That is Paget's disease, right? So the epidermis is now involved. And so now you find essentially abnormal cells in the epidermis of the skin of the nipple. And so this could be associated with underlying invasive carcinoma. And these patients have an eczematous, ulcerated, bleeding, and or scaly nipple. It tends to only be unilateral, and you might feel a mass as well because there might be an invasive carcinoma. Okay, so the main thing is that with Paget's disease, normally in question stems, you will find that one of the answers will be Paget's disease and one of the answers will be eczema of the breast. You can get eczema of the nipple. The difference is that eczema, if it happens, is normally affecting sort of the actual breast skin, and it's coming up to the areola, but it doesn't tend to involve the nipple itself. Whereas Paget's disease going the other way, okay? So you start with your nipple, then you affect your areola and so on. So if it is affecting the nipple and the areola directly, it's much more likely to be Paget's disease of the nipple. If it's affecting the breast skin and not really necessarily much of the nipple or areola, then it's much more likely to be eczema. So just be aware of that. And you're going to see these irregular malignant cells in the epidermis. Obviously, you're going to need to excise that lesion. Then you have invasive breast cancer. This case, you're having this painless, hard, irregular breast lump, can be associated with skin changes. So nipple inversion, retraction, skin tethering, discharge, skin puckering. You can get peau d'orange, which is basically when you get essentially blockage of your lymphatic system. So you essentially get this kind of dimpling of the skin, kind of resembles an orange peel, which is hence the name. And essentially, in this case, you have malignant cells and they've invaded through the basement membrane. It's pretty much always a ductal carcinoma. So we've been talking about ductal cells this whole time. That is the most common type. But you can also have lobular carcinoma, which is much more rare. You might have mixed, and it might even be inflammatory, which is carrying a much worse prognosis. You need to be aware of the key sites that it will metastasize to. So lung, liver, bone, brain, those are your classical ones. And when we talk about breast cancer, you're commonly thinking of doing triple assessment. So that means you're doing a clinical examination, so breast examination, history taking, and so on. Then you're doing imaging, so ultrasound if they're under the age of 30, because the breast tissue is very dense. And if they're older the age of 30, you can think about mammogram because it's an X-ray, so it'll be able to penetrate once they're over 30 because the breast becomes more fatty, less dense. And then your biopsy, that's your other part of your triple assessment. And then genetic testing for things like estrogen receptors, progesterone receptors, and HER2. And that's just going to allow you to do some targeted therapy, okay? So this is, as I've just said, and also BRCA, because you obviously want to know for family members, and also for whether they have an increased risk of ovarian cancer, because you can do a prophylactic oophorectomy where you remove the ovaries as well. These are a couple of extra things. You can get benign cysts within the breast. You can also get galactoseals, which is essentially a cyst, but now it's filled with breast milk, and that's because your ducts are basically obstructed. And so it will essentially prevent drainage, and then you get a milk-filled cyst. They normally all resolve, both of these. And this is just to say that in the UK, we have a screening program for breast cancer, which is a mammogram every 3 years once the patient's 50 to 70 years old. And you obviously want to consider your further history and your family history as well. This is from my notes. I don't know how useful this is to you. I thought it was useful to me at the time, but maybe it won't be. This is just like basically based on your different symptoms. I think I just got this from LabMed, one of the lectures. But essentially, if you think about discharge, you can separate it into unilateral or bilateral, and then kind of separate your differentials that way. If you have lumps, you can kind of think, are there multiple lumps? Are they, round and well circumscribed and mobile, where it's much more likely to be a fibroadenoma versus a fibrocystic change, versus whether there's any kind of skin changes, sorry. Pain, if there's pain and there's lumps, if there's no pain, and so on, and then also your different kinds of skin changes. So this is mostly for your revision. And we can do a couple of questions on this and then move on to gynae. I think we're running a tiny bit behind, guys. I'm so sorry. Um, there's quite a lot of topics to cover, and I just wanted to give you some questions as well, to be useful for your revision. Yes, so this patient has mastitis. The first line management is going to be continue breastfeeding because if she doesn't continue breastfeeding, what you get is milk stasis. The milk will be static and it will be much more likely to pick up an infection. At this point, she has all of her observations are normal. So there's no need to give her antibiotics because she's unlikely to have a systemic infection, okay? The antibiotics might be needed if she develops a fever, if she becomes unwell in another way. Right now, it's just redness and tenderness, so just inflammation, basically. If she does start antibiotics, a lot of people are often confused about this with stop breastfeeding. So you don't stop breastfeeding. Sorry, you do stop breastfeeding if you give antibiotics, but it's not. Well, you can sometimes continue breastfeeding, but if they're worried about passing on the infection, what you can do is get them to pump and dump. So you do not want to stop the flow of milk entirely because otherwise it's just not going to resolve. So if you give antibiotics and there's a lot of infection, then you'd get them to pump and dump, and then there's no risk of kind of the baby getting any kind of infection or having milk that's got pus in it and stuff like that, which is quite gross. But if it's very mild, you can give antibiotics and she can still do a bit of breastfeeding, or she can feed from the other breast and do pump and dump on the infected breast, if that makes sense. Okay, next one. Okay. Well-defined. This is a well-defined lump, upper outer quadrant, moves freely, so it's very mobile, non-tender. Perfect. Fibroadenoma. So the breast mouse, as it's so-called, highly mobile, very common in the under 30s. Lovely. Completely benign. Obviously, on histology for fibroadenoma, you're going to see that mixed epithelial and stromal proliferation. Okay, so we're talking about someone who's got blood-stained discharge, but no other symptoms. What's going to be your diagnosis? Um, all right. Yeah, so this one's tricky, I guess, because what you're looking for is so the blood-stained discharge, very characteristic of a ductal papilloma. So this is the benign epithelial proliferation, essentially. So it's happening in the ducts. The ducts are basically going to be proliferating in excess, and so you get a papilloma. You don't, if you remember, ductal carcinoma in situ is essentially completely asymptomatic. We almost never pick it up in clinical practice unless it's associated with Paget's disease of the nipple. So even though a DCIS is kind of worse in some respects than a ductal papilloma because it's a carcinoma, it just hasn't invaded yet. It doesn't tend to produce a blood-stained discharge. Typically, only in a couple of cases you will see some kind of symptoms. Mammary duct ectasia is your green cheesy discharge. Okay, that's a slightly different discharge than you have with ductal papilloma. And with ductal papilloma, the blood-stained discharge is typically the only feature. There's no other associations. Okay, I think this, yeah, two more, and then we'll move on to gynae. Okay, so we want to be thinking about the features here. So we have painless, hard, non-mobile lump. So yeah. All right. So we obviously are going to be referring urgently to the breast team. This is a bit divided, so I'll just go through it. So red flag features, right? No pain, it's painless, it's hard, it's not mobile. All of these things are very, very suggestive of a cancer, a carcinoma. So you really need to do a 2-week wait referral. Routine referral, obviously, a lot of you went for routine referral. I'm hoping it's just because you didn't get to E. Routine referral is if it's kind of a very benign pathology, you can consider a routine referral. But obviously, if you have red flag features, you're automatically going to be doing a urgent referral. Take a biopsy. Yes, you will take a biopsy, but you probably won't. There'll probably be the specialist team who will do it, and that will be part of triple assessment, right? It's going to be clinical examination, imaging, so ultrasound slash mammogram. In this case, it's probably mammogram because she's old enough for it, plus a biopsy. Okay, I think this is the last one. Oh no, this is okay. I will stop there for this one. And we'll move on to gynae because the next questions are about gynae stuff. Hopefully, it's not going to take too much longer of your time. Okay. So gynae, I've kind of just split it up based on the different reproductive organs. So obviously uterus is got benign and malignant pathologies. This is the central part. The bottom of the uterus is essentially called the cervix. Then you have your fallopian tubes, your ovaries. Obviously your vagina is connects the outside external genitalia, so the vulva, to the cervix and the uterus. So that's the canal there. And obviously, each of these different organs can be has their own set of conditions that you might need to be aware of. I would say the key ones tend to be involving the uterus, cervix, and the ovaries. And then there's a couple other things that that you might need to be aware of as well. So we'll go through those. This is just kind of like the different terminology that we use in gynae to describe different things. You can have a look at this in your own time. I think a lot of you guys will be aware of many of these anyway, and I'll explain if they come up as I go along. So this is your uterus, has a fundus right at the top here, and then it's essentially got the cervix at the bottom here. This is the isthmus or the neck region, which basically connects the uterus to the cervix. So cervix is technically still part of the uterus in a way, it's just the bottom part. And then this is the body, the main body of the uterus. Uterus has it's lined by the endometrium, and then you have the myometrium or the muscle layer underneath, and then outside of that you have the serosa. Okay. So if you have uterine disease, how is a patient going to present? Well, obviously this is the uterus lined by the endometrium, so you're going to probably be getting some kind of abnormal vaginal bleeding, so PV bleed. So as in the blood is coming from the uterus through the vagina. That's what that means. So menorrhagia, heavy bleeding, dysmenorrhea, painful periods. Metrorrhagia just means irregular periods. So that means kind of intermenstrual or postmenopausal bleeding, or also postcoital bleeding, sometimes less. That means like after sex, that's less common with uterine disease, but can also happen. And then pelvic pain as well. Pelvic pain, why? Because it's normally coming from the contractions of the myometrium. Okay, so in the uterus, you have benign conditions. You have things like endometritis, so inflammation of the endometrium. This can be acute, which is quite uncommon actually. And this would be more likely if you have some kind of bacterial infection after you've had a baby or a miscarriage, essentially when the cervix or the cervical os is open. If you have chronic endometritis, this is more common, and this tends to be in patients who have a chronic pelvic inflammatory disease. Maybe they have some retained products of conception, so they might have had a termination of pregnancy, but there's still some pregnancy tissue within the uterus that basically causes inflammation. It might be after an IUD insertion, might be because of TB. Here you do STI swabs on these patients because it can be linked with STIs, and you'll see plasma cells in the endometrium, which is your hallmark of chronic endometritis. You can also get polyps. So endometrial polyps, these are a very classical cause of abnormal uterine bleeding, and it's a common cause of postmenopausal bleeding. So Postmenopausal bleeding, whenever you hear about postmenopausal bleeding, always, always, always think about endometrial cancer. But your differential, if it's not endometrial cancer, it could be an endometrial polyp. So it's just an outgrowth in the endometrium, okay? These are the two differentials for this presentation. This is just benign. Obviously, it's an overgrowth of the endometrium, so both glands and stroma. And it can be associated with tamoxifen, which you give for breast cancer, which is also a driver of endometrial cancer. So obviously you want to do a transvaginal ultrasound. You can actually just get rid of that polyp via hysteroscopy with a polypectomy. And obviously on biopsy, you would see haphazard, irregular glands. They're cystic and they tend to be surrounded by stroma. So glands and stroma, they're just normal endometrium, but they're in the form of a polyp. Endometriosis, this is a very chronic condition associated with a lot of pelvic pain, a lot of painful periods, deep dyspareunia, which basically means painful sex, but not on initial penetration. It's felt deeper within the pelvis, if that makes sense. You get cyclical symptoms because it tends to be hormonally driven disease, and you get this endometrial tissue that's migrated to other areas. So you essentially have endometrial tissue outside of the uterus, and that endometrial tissue, wherever it is in the body, could be things like, around the pelvis, in the ovaries, in the form of like a cyst, for instance. And wherever that endometrial tissue is, it bleeds and it sheds just like a normal period. But the problem is there's nowhere for that blood to go. And so it's really, really painful. And you get pain kind of in all of those different areas of the pelvis and wherever the deposits are. And those deposits could be widespread, could be in the lungs, could be in the brain, very rarely, but it can be. This can cause a lot of adhesions within the pelvis, so where the different organs stick together. And it can also cause things like, as I said, a catamenial pneumothorax. So this is essentially where you get a pneumothorax with your period. So that can be quite cyclical as well. And that's if you have endometriosis in the chest. This is very rare, but anyway. Diagnostic laparoscopy is your gold standard for diagnosis. However, you can, and we're getting better at detecting this with transvaginal ultrasound and with MRI as well. Adenomyosis is effectively endometriosis, but in this case, the endometrial tissue is in the myometrium. So it's basically just invaded into the muscle wall of the uterus. And so in this case, your main symptoms are going to be painful periods again, because now you're bleeding into the muscle wall, and heavy bleeding. So heavy bleeding, why do you get heavy bleeding? So I think a lot of people wonder, why don't you get heavy bleeding with endometriosis, but you get heavy bleeding with adenomyosis? This is because when you have a period, the way the bleeding is stopped normally is your uterus contracts, okay? The muscle, the myometrium contracts, and it basically causes those spiral arteries, which are the things that are bleeding, to essentially shut. So it basically, you're shedding the endometrial layer, and you have these open spiral arteries, and then the myometrium contracts, and it basically squeezes those spiral arteries, and you stop bleeding. But of course, if you have endometrial tissue within the myometrium, you can't contract as efficiently as you can before. And so as a result, those spiral arteries stay open. They're not completely squeezed shut. And so you keep bleeding. And that's why you get heavy bleeding with fibroids as well, which we're coming on to in a second. So in this case, again, you see benign endometrial stroma and glands in the myometrium. And you're much more likely, sorry, my cat's at the door. You're much more likely to get adenomyosis if you have had multiple pregnancies in the past. It's thought, but this is kind of changing now that diagnosis is improving. Fibroids are your benign smooth muscle tumors, also called leiomyomas. These can be asymptomatic. A lot of women have fibroids and know nothing about it. But it can also cause very heavy bleeding, menorrhagia, as I just described the mechanism, because you're getting this smooth muscle tumors of the myometrium, okay? These are growth sensitive to hormones, so progesterone and estrogen, and they tend to regress after menopause. And so essentially in this case, you can also cause, because they can grow very, very large, you can get pressure effects, so bowel and bladder symptoms, urinary incontinence, and so on. But in general, if you did a biopsy, you would see bland spindle-shaped cells, and you tend to have these rubbery white encapsulated lesions with like a whorled surface. Okay, so now onto the malignant endometrial conditions. You have endometrial hyperplasia, which is not necessarily malignant on its own, but you can have endometrial hyperplasia without atopia and with atopia. So in this case, what you have is excess glandular proliferation, and you have more glands than stroma. So these are your glands, and these are your stroma in your normal endometrium. Then if you have it without atopia, you get more glands, less stroma. And then if you have with atopia, now you're starting to get nuclear atopia. So the nuclei are looking abnormal. You can see here they're much more blue, much more different, way more glands, much less stroma. That's how you're going to know the difference. And this is typically driven by prolonged estrogen exposure that is unopposed by progesterone. So you guys know that estrogen drives proliferation of the endometrial glands, and progesterone stabilizes the endometrium. So yeah, normally what you need is a combination of estrogen and progesterone to maintain a nice endometrial layer that's not too thick. But obviously, if you have a lot of estrogen for whatever reason, maybe obesity, because you get more conversion of androgens to estrogen in fat cells, maybe because you are on HRT, you just have an estrogen component, no progesterone component, which you should never have. But let's say that is another risk factor if you're on tamoxifen, because it is an estrogen agonist in the endometrium, estrogen antagonist in the breast. That's a bit confusing, but just to say. And so this is going to present with your classic uterine symptoms, abnormal bleeding, intermenstrual bleeding, postmenopausal bleeding, and so on. And you would basically do hysteroscopy and a biopsy. And you're really looking for a thickened endometrium, which is going to tell you that there's likely to be some hyperplasia, if not cancer. And then obviously this can progress to endometrial carcinoma. So there is different types of endometrial carcinoma, but the main one is type 1, which is an endometrioid endometrial carcinoma. This is estrogen dependent. So this is driven by estrogen. So obviously these are your key risk factors. You're going to get a lot of proliferative glands. And then those glands, because there's so many of them, are going to fuse, and you get what's called like cribriforming when the glands are just stuck together. You're going to get a lot of cytological atopia, and you might have mutations in PTEN. Type 2 is your endometrial serous carcinoma. So this is estrogen independent, much more likely in older women, and the biopsy is going to show a lot of papillary and or glandular architecture that has very diffuse marked nuclear pleomorphism. This one is much more, this has a much worse prognosis. Basically, you have a lot more distinct differences in your cells, so they look very, very abnormal, associated with mutations in TP53, the tumor suppressor gene. And you also have other types of endometrial carcinoma, which are also technically fall under type 2, clear cell carcinoma, carcinosarcoma, but these are very rare, unlikely to come up. And again, we want to do hysteroscopy and biopsy. Then we can also get conditions that are associated with pregnancy. So this is something called a hydatidiform mole or a molar pregnancy. So this is because you have like essentially how you distinguish it is by these water accumulation in like cysts within the uterus. So the reason that they happen is essentially because you get a lot of proliferation of the trophoblast, the bit of tissue that will eventually become the placenta. And then you get sort of edema in that tissue, and that causes kind of these villus hydrops, so these kind of fluid-filled areas. And this is because of genetic abnormalities. So essentially, you normally have one sperm, one egg, but if it's a complete mole, what happens is that you have two sperm, but they fertilize an empty egg, so there's no maternal DNA within the egg, and so this is obviously destined for failure. This is unviable. You can have a partial mole where you have two sperm fertilize a single egg, and now you essentially have 3 sets of chromosomes instead of 2. So that's obviously problematic as well. And essentially, these are your risk factors. You will know about this because you're going to see kind of a snowstorm appearance from those those villus high drops on ultrasound. And the question stem will often say that their uterus is large for dates. So instead of expecting a 12-week pregnancy, they're going to look like they're much more pregnant than they are, for instance. And they have these kind of grape-like fluid-filled chorionic villi that are normally going to be forming the placenta, and they fill the entire uterine cavity. The reason we care about molar pregnancies is there a risk of a cancer called choriocarcinoma, which is a very rare but a very serious cancer. And it's very responsive to chemotherapy. So we want to try and detect it. And the way that we detect it is we do follow-up serial beta HCG measurements. Obviously, once you've gotten rid of the pregnancy, you should have your HCG fall back down to 0. So you'll do serial measurements to make sure that is the case. And if not, then you refer them to specialist unit. Okay. Some benign conditions that you'll need to be aware of is pelvic inflammatory disease. So this is kind of inflammation of your pelvic organs, usually because you get an ascending infection that's coming from the cervix upwards into the reproductive tract. It can involve sort of all of the different organs, commonly caused by STIs, so things like chlamydia, which is most common, gonorrhea. Sometimes you can get it after abdominal surgery, so the infection descends instead of ascends, but that's rare. So obviously risk factors are the things that are associated with those, as you might expect. And ultimately, this can lead to sepsis. You can get tubo-ovarian abscesses. You can get a specific type of perihepatitis called Fitzhugh-Curtis syndrome. It can lead to infertility because the fallopian tubes get blocked and have adhesions after all the inflammation that happens. You can get a lot of pain, and then as a result, you can also end up with a risk factor for ectopic pregnancy. So again, you are going to get a lot of pelvic or low abdominal pain, deep dyspareunia, abnormal discharge, bleeding, and so on. Cervicitis just refers to inflammation of the cervix. Again, this can be caused by STIs, and the cervix if you have cervix inflammation, your very common symptom of inflammation of the cervix is post-coital bleeding. So after sex, essentially normally penetrative sex, because of the friction on the cervix, you promote the bleeding because there's a lot of inflammation and vessels in the area. It's a very vascular structure. So that's your key symptom for any cervical problems. And you'll also get increased discharge as well. So the key thing to be aware of with the cervix is obviously it is linked with cervical cancer, for which we have a really great cervical screening program. And that cervical screening program is based on detection of high-risk HPV strains, which are affecting what's known as the transformation zone. So it's just important to be aware of what this is. So effectively, in your cervix, you have your endocervix, the bit that's inside, and then the ectocervix, the bit that's facing the vagina. And what happens is that around the time of puberty, some of your endocervical cells, which are columnar cells, they're going to migrate downwards into the transformation zone where you switch from this columnar cell to the squamous cell of the vagina. So you have this switch, and they'll migrate outwards, and they essentially evert. And when they do that, they basically transform. So they undergo this process called metaplasia, i.e., they switch from columnar cells to squamous cells. And so this is called your transformation zone, this area of metaplasia. And you can see it on a speculum examination. And that is where most of your cervical cancers arise, because these cells tend to be quite they're quite proliferative. And so HPV is more likely to target these cells. Okay, so you do need to know about cervical cancer, and it comes up a lot. So as I just said, it's typically driven by, well, we know pretty much most of cervical cancer is driven by HPV, high-risk HPV strains, things like HPV 16 and 18, but there's loads of different strains. And what will happen is that this is essentially going to kind of integrate into the genome, and it will cause cell changes. And these cell changes are called cervical intraepithelial neoplasia, or CIN. And that's a precursor. It's not cancer, but it can become cancer. And if it becomes cancer, it tends to become cervical squamous cell carcinoma, okay, which is your commonest type of cervical cancer. You can also get adenocarcinoma in the cervix, which is driven by, well, your precursor lesion will be your glandular intraepithelial neoplasia, cervical CGIN. And as with all of these precursor lesions, there's no invasion of your basement membrane. And then essentially, how you're going to investigate this is you do colposcopy, where you basically use a speculum to look at the cervix and a microscope, and then you can take biopsies as you need, and you can basically diagnose it that way. So that is the cervical screening program. So normally what we're doing is it's testing for the presence of high-risk HPV first with your smear test. So essentially you're just literally brushing some cells from the cervix and sending them off for HPV testing. If there's high-risk HPV detected, then what you'll do from there is you will look at the cells under the microscope, so cytology. And if those cells look abnormal, i.e. they have dyskaryosis, so they look abnormal, you refer the patient for colposcopy, which is when you can take a biopsy. So that's really what we know, what the screening program is, and that's what you should know. And you can also vaccinate against high-risk HPV. And this is, rolled out now across the UK, I think, for everyone aged 12 to 13. Many of you may have had this vaccine. It's now, I think, Gardasil 9 that we're doing, which is protecting against these different HPV strains, some of which are low-risk ones, like 6 and 11, but some of which are high risk as well. And now the screening program's just changed. I hope that they have highlighted this in your lectures, but effectively the interval now is every 5 years for 25 to 64-year-olds. You might need to be aware of the previous screening program intervals, which is every 3 years up until, I think, 49, and then every 5 years from 50 to 64. But for now, I would say this is obviously key, so just remember this. Okay, so moving on to the tubes and the ovaries, you can get inflammation of the fallopian tubes, salpingitis. This again can be caused by things like STIs, TB, and what you'll be presenting with is things like classical symptoms like vaginal discharge, pelvic pain, lower back pain, because the tubes are kind of quite far back in the pelvis, pain with sex, and painful periods as well. You can also get cysts that are involving the ovary, so follicular cyst. You can also get a corpus luteal cyst. So once you've kind of released the egg from the ovary, the corpus luteum can then form a cyst itself. And essentially these cysts, the main complication to be aware of is they can make the ovary a bit heavy, and so it can be prone to torsion. And that will obviously be a surgical emergency. Otherwise, you might lose the ovary because you block the blood supply to the ovary. And you get a lot of pelvic pain with that, especially with torsion. And with torsion, the pain is normally worsening. It never gets better. And it tends to be triggered by things like exercise, heavy exercise, for instance, because when you're doing a lot of exercise, your ovary might just twist around, and that is the key risk factor you need to be aware of. The ovarian tumors are kind of a minefield. I would say that you don't really need to learn a huge amount about them. Just learn how to recognize what they are based on their name. So this is what I think is the easiest thing to do. So what you should know is that the most common benign tumor of the ovary is a serous cyst adenoma. So adenoma is always benign. Adenocarcinoma is always malignant. So the most common malignant one is a serous cyst adenocarcinoma. How are you going to remember this? So there's different types, right? Serous means mucus producing. What produces mucus in the reproductive tract? Normally the fallopian tube. Okay, that's the one that's kind of producing kind of some kind of like mucin. And so what you need to know about ovarian tumors is that very often what we know is that they arise from the end of the fallopian tube. It's a bit confusing, but they tend to arise from the end of the fallopian tube and grow onto the ovary. So yeah, that's why these are the most common ones. But you can also get ones that are mucinous. You can also get endometrioid ones. You can also get clear cell ones. There's a bunch of different types. There's like Brenner tumors, mixed ones, and so on. But I would say learn these. And then the other ones you can probably distinguish based on the question stem, like what the histology is. That's what I would. So if it looks like fallopian tube histology, then it's likely to be a serous cystadenoma. I hope that makes sense. If I've explained it badly, please tell me. Ovarian tumors typically present with non-specific symptoms, bloating, early satiety, anorexia, and a lot of pelvic pain. And what you want to do is your screening test, which is a CA125. It's not sensitive or specific because it can be raised with other ovarian pathologies like ovarian cysts and so on. But it's a really good kind of like rule out test in the sense that if it's negative, you're less worried about ovarian tumors, but it doesn't rule out the fact that it could be an ovarian tumor, if that makes sense. So it should still be on your radar, but you're reassured if it's low. Then you have ovarian germ cell tumors. So these are things like your mature cystic teratoma, which is also known as a dermoid cyst. Teratoma means it has all of the different germ cell layers, so endoderm, mesoderm, ectoderm. And you can obviously these can rupture and they can cause ovarian torsion because they're very heavy because they actually contain like actual tissue. So they're worse than even a cyst for torsion. You can also have immature cystic teratomas, which are your malignant type. You can have other types of teratomas, dysgerminomas, which is kind of similar to the seminoma of the testes, yolk sac tumors, choriocarcinoma, which is like what we spoke of before. And ultimately, you want to use LDH as your tumor marker here, but again, non-specific. It just might help you if you're worried about this. And you can also get symptoms that are related to the tissue type of the germ cell layer. So, you can get thyroid tissue in the teratomas, and then you can get sort of thyrotoxicosis, for instance. Then you have sex cord or stromal tumors. So these are essentially tumors like granulosa cell tumors that secrete estrogen and can cause endometrial cancer, thecomas that also secrete estrogen and can cause endometrial cancer, the Sertoli or Leydig cell tumors, which secrete androgens, and then your fibromas. So these are kind of, the fibroma is entirely benign, but it can cause something called Meigs syndrome, where it irritates the peritoneum and it can cause ascites. And then that ascites can lead to pleural effusion because of fluid shift. So that's the main thing to be aware of. It's benign, but it can cause this problem. Yeah, you have the standard symptoms of ovarian tumors, but in this case, your tumor markers are AFP and HCG. Okay, moving on to the vulva, you have benign pathologies like a Bartholin's cyst. This is essentially coming from the Bartholin's glands because you get obstruction of the Bartholin's duct. And so you basically get these, so this is the duct and this is the gland, and this is kind of sitting sort of at the introitus, so kind of the entry point to the vagina. And so you'll get these enlargements and they tend to be kind of benign. They can get infected, and if they're infected, they might be tender and inflamed, and they might need sort of incision and drainage as with your standard abscesses. You can also get lichen sclerosis, which is essentially where you get atrophy of the epidermis of the vulva, and you get a lot of fibrosis and scar tissue formation. So in this case, you get sort of discoloration of the skin, tends to get much paler than normal, and it's pretty itchy, and it causes, in this case, superficial dyspareunia. So you have pain on penetration as opposed to deeper pain within the pelvis during sex. And for these patients, the key thing to be aware of is that it is linked with a progression to vulval cancer, and this will be HPV independent vulval cancer. You can get vulval cancer that's linked to HPV, but if it's HPV independent, it's commonly occurring on a background of lichen sclerosis. So vulval carcinoma, similar to the cervix, preceded by your precursor lesions, so vulval epithelial neoplasia. It's most commonly a squamous cell carcinoma, and as I said, can be linked to HPV or not. You can get other types, but these are small print. You could also get a malignant melanoma, and essentially risk factors are to do with HPV, immunosuppression, if you have lichen sclerosis, and so on. And so, your diagnosis is going to be very similar to cervical cancer. So you want to take a biopsy, and obviously you're going to see your classic SCC markers on histology. Okay, sorry, I know that was kind of like a whirlwind stop of gynae, Some of the other pathologies are a little bit small print, so I just thought we could do the questions and hopefully catch most of the key things. But if everyone needs to go, just let me know. Okay, so we're talking about someone coming with fever and suprapubic pain. Yes, good. Okay, so what is the most likely organism? Chlamydia. So what does this patient have? So this is 24-year-old female, fever, suprapubic pain. So this is kind of a classical presentation of PID, pelvic inflammatory disease. They then have, free fluid and pelvic fat stranding. So those are all kind of signs of inflammation of the pelvis. So that is your diagnosis for PID. Most common causative organism of PID is chlamydia. That's just one of those things that you kind of need to know. Gonorrhea can also cause it. It's just less likely. It's not commonly linked with E. coli or Pseudomonas, though obviously not impossible. Okay, so this patient's postmenopausal bleed. So I hope I've kind of drilled it into your heads. Postmenopausal bleed, always think about endometrial cancer. That's your key uh, differential that you need to rule out. So we're just thinking about things that increase risk of endometrial cancer. Perfect. Yes. So Lynch syndrome increases your risk. Lynch syndrome also increases your risk of colorectal cancer, as you might be aware of. So the other ones, the Mirena coil is releasing progesterone. So that's actually protective because it will oppose estrogen. Remember that a lot of endometrial cancers, most of them are estrogen driven. So Mirena coil is actually protective because it opposes estrogen by providing progesterone, I should say. The combined pill also doesn't really um, uh, increase your risk of endometrial cancer. Again, it tends to be protective just by balancing out the amount of estrogen exposure that you have. Okay, so the key symptoms here, worsening pain, and it's not responsive to painkillers. Also dyspareunia, so pain during intercourse, and subfertility, trying to conceive but failed. So trying to conceive but failed could be infertility, might just be subfertility, and then here you see some nodularity and tenderness. So this is characteristic of endometriosis, right? Painful periods, as well as pain during sex, which tends to be a deep dyspareunia. Um, Fibroids, as we talked about, because they're in the muscle wall, they're much more associated with heavy bleeding, okay, because we can't stop those spiral arteries from kind of hemorrhaging out. Interstitial cystitis is to do with the bladder. Um, the stem mentions dysuria and urgency, but that could be because of the um, endometriosis affecting those organs. So not necessarily, and the interstitial cystitis would not explain the period symptoms. Okay, so I'm hoping that if not by now, because I didn't really go over it too much, but by the end of the year, if somebody says to you severe right iliac fossa pain and vomiting in a young female, you're going to be thinking ectopic pregnancy, but we know that the pregnancy test is negative, so that's not going to be the diagnosis in this case. So what else can cause this, especially after heavy exercise? So what you're thinking of, I can actually show the explanation. So you want to be thinking of ovarian torsion. As I said, ovarian torsion can come up after exercise. And if you're looking for ovarian pathology, the best way to detect it is via ultrasound scan. So that's why that's the right answer here. Okay, so postmenopausal bleeding, guys. So what are we thinking about with postmenopausal bleeding? They also mention obese and hypertensive, which are risk factors for which of these? Endometrial cancer, yes. So, perfect. So postmenopausal bleeding, you're always thinking of endometrial carcinoma. Um, Cervical screening, yes, was 14 years ago, but cervical cancer much more likely in the younger population. It's cancer of the young because of the link with HPV. Also, 14 years ago, remember cervical screening program ends around 65. So that's not really a problem. Obese and hypertensive, both risk factors for increased levels of estrogen and therefore endometrial adenocarcinoma. So yeah, that's why that's the answer and not SCC of the cervix. Also, as I said, with the cervix, what is going to be your main symptom is postcoital bleeding, okay, not postmenopausal bleeding. Okay, sudden onset pain with vaginal bleeding and shoulder tip pain. So shoulder tip pain, I'm sure you guys are aware of this. This is because of irritation of the phrenic nerve, right? Of the di which innervates the diaphragm and was referred C3, C4, C5, so up to the shoulder tip. So this is we are worrying about an ectopic. Why are we worrying about an ectopic? So to get shoulder tip pain, you need to irritate the diaphragm. If you're thinking of pelvic inflammatory disease, that's in the pelvis. It's quite a long way away from the diaphragm, right? So why is the answer ectopic? Because if an ectopic ruptures, you get a lot of blood, and that blood enters the peritoneum. And if you're in the peritoneal cavity, that blood can travel all the way up to the diaphragm, irritate the diaphragm, and cause shoulder tip pain. So that's why the answer is an ectopic, not pelvic inflammatory disease, which would cause a lot of pain, but it wouldn't be quite so sudden onset in this way and not described as sharp or tearing. So that's why that is the answer. Also, this patient's hemodynamically unstable, hypotensive, tachycardic. So that's why the answer is ectopic. Okay, this is just your risk factors for cervical cancer. I hope that I have emphasized this point. HPV, perfect. High risk HPV strain 16 and 18, 6 and 11 are low risk HPV. All right, that's everything that I have for you guys. I'm so sorry that we're 30 minutes late, but please fill in the feedback form and we can send across the slides. And obviously, really good luck for your formative. I'm sure it will be absolutely fine. Thanks for coming.